Hi, I'm Matt Collins, and today I'm going to be performing paediatric cannulation. Indications for IV cannulation of pediatrics include pain relief, cardiac arrest, fluid administration, and also medication administration, for example, dextrose, adrenaline, and antibiotics. When cannulating the pediatric, there are some things that you can do to make life easier for you. Things include the mother to hold the child. Often in pre-hospital care, the child will usually be pretty unwell, so they might not be thrashing around, crying, which would making it a hindrance. So getting the child to be held by the mother. Also at home, not really for us in the ambulance, but maybe some oral sucrose on a pacifier, which is encouraged by the Royal Children's. And some distraction techniques, use of TVs and toys and relaxation, play therapy, getting the mother to play and distract the child whilst trying to cannulate the patient. Not applicable to pre-hospital setting, but the use of a topical anaesthetic cream is available for pediatric cannulation in hospital. And also for kids, needles are often the most feared painful procedure by kids, so settling the patient, reassuring them, and reassuring the mother can also go a long way. The use of the cephalic and basilic veins in the upper arm, avoid these, as these are usually reserved for the critically unwell children at the kids, and as shown on the slide as to why this is and what they're used for. When thinking about cannulating a pediatric, you need to think of some things. Does the pediatric need to be cannulated? Can you manage without an IV access? Involve the mother at all times and make sure you gain their consent. Also, use the non-dominant hand, and also the utilisation of another paramedic or another family member to help stabilise the arm and keep this still can make cannulation attempts easier and more successful. Vein selection for pediatric cannulation. Ideal spots are the cephalic vein of the forearm, the dorsal digital and venous arch of the back of the hand between the fourth and fifth metacarpal, ideal spots for the back of the hand, and also the saphenous vein anterior to the medial malleolus of the ankle for the pediatric. The use of a transilluminator can assist in finding difficult veins in critically unwell patients when IV access is required. When cannulating kids, you need to modify your technique a little bit. When advancing in through the skin initially, you need a lesser degree of an angle compared to adults. You need no more than 10 degrees or so. That's what's recommended by the Royal Children's. And once you get your flashback, don't advance the cannula any more than a mil, as the vein in a pediatric is so small, you have a more higher tendency to pierce through the back side of the vein and tissue you cannulate and lose access. As per any procedure, I've set up my equipment prior to doing the procedure. Here I've got my tourniquet, my tegaderm, my 3-way tap, extension tap, my 2 cannulas, size 22 and size 24 gauge, which are utilised for pediatrics, alcohol swab, safety goggles, tape, bandaging so that I can wrap the pediatrics cannula up, a little arm board, and a sharps container. Applying a tourniquet proximal to the arm, placing a finger underneath the tourniquet, ensuring that it's not too tight, and then checking to make sure you can still feel a distal pulse. Locating an appropriate vein, here the cephalic vein of the forearm of the child, and then grabbing an alcohol swab and cleansing the area and making sure that it is dry before proceeding. Whilst waiting for the antiseptic to dry, I can prepare all my equipment further. I get my tegaderm out, I draw up two 10mm normal saline flushes, and I prime my 3-way extension tap ready for when I need to attach to my cannula. What I'm doing here, as it can be difficult when placing an IV into a small child because of their small veins to get reasonable flashback, I am flushing the cannula with some normal saline, so when I get that tiny little bit of flashback, the blood will dilute into the normal saline within the cannula, and this can show me that I'm within the vein. For small infants, a tourniquet isn't required, and I can utilise this technique for IV cannulation. When I'm ready to cannulate the patient, I alert the patient that there's going to be a sharp scratch or a sharp prick prior to insertion of the cannula. At a small angle, no more than 10 degrees for a paediatric, I advance the needle through the skin until I get flashback into my cannula. I advance the needle 1mm more, no further, as the paediatric has small veins. I remove the tourniquet and I pinch off the cannula to tamponade. I remove the cannula, calling sharps out. I then attach the 3-way extension tubing and secure with a tegaderm. To secure the cannula and the 3-way extension tubing, I place some tape underneath the tubing and fold it back over the cannula. Next I place some tubing over the hub of the cannula and then further to the 3-way extension tubing to further secure the cannula into place. Then I flush the cannula with 2 to 5 ml of normal saline. Once the cannula has been secured, the patient's arm can be splintered using an arm board and some crate bandaging. This can assist with movement from the paediatric and dislodgement of the cannula. And it can be formed like so, with the end of the 3-way extension tubing accessible for medication administration.